Hello and welcome back. Now in the previous class we learnt about the anatomy, the physiology of the breast and a brief introduction into carcinoma of the breast and its symptomatology. Now in this class let's look at history and clinical examination of a patient who presents with a breast lump. Now this is probably the most important because it comes as a major case and you need to know what are the important points that you need to look for. So what are the possible breast lumps that you see in your OPD basis or the possible exam cases that you're going to get? One is it could be a carcinoma of the breast. Second, it can be a phyllodes tumor, or sometimes they might even give you fibroadenoma as a short case. As a short case in your exam. And please keep it in mind, it is not only the lump you are bothered about, you also need to look for signs of metastasis or local spread either to the lymph nodes or to various other organs. So when it comes to history, and in that also patient demographics, alright. Most important is the age and sex. We have already discussed this. More is the age, higher is the risk. Female gender has higher risk. But if you have a patient who is male who presents with breast lump, it is malignant unless otherwise proved. Okay, unless otherwise proved, it has to be considered as a malignant lump. Now the other factors, till what education the patient has studied, where she is coming from, what schooling she did, all that, to be honest, will not give you any extra information to your history. So I normally wouldn't mention all this in a long case. What's probably that you can mention is the socioeconomic status, because I believe that people with higher socioeconomic status tend to have a high consumption of fats in their diets because of all these change in lifestyle where you eat burgers, pizzas with a lot of cheese, and also high fat content means more peripheral conversion into estrogen and possibly a higher risk of developing malignancy. And they also feel that nulliparity is a part and parcel of the affluent family, because where they tend to delay having a child because of their lifestyle and their work pressure and so on and so forth. So you can defend, if the examiner asks you why did you ask for socioeconomic status, you can defend by telling these 2 points. So the chief complaint will usually be a lump in the right or the left breast since so many years, months or days. If there is an ulceration, you have to mention the ulceration as well in the chief complaint. They presented with lumps in so many days and ulcer since so many hours or so many weeks, or the shorter of the 2 durations. Now in HOPI, the common thing is you guys tend to write a big list and it gets jumbled up. Don't do that, and you will tend to forget 1 or 2 important points as well. So please classify it. It will be very easy for you. First is talk about history with respect to the lump. With respect to the lump, you're going to talk about onset, duration, progression. This is the classic explanation for any possible swelling. Next, whether there is any pain or ulceration. After the lump, next you move on to the nipple, whether there is any discharge or retraction from the nipple. Then local spread. We have said now that we have finished the breast, from the breast where can it go to? First is the axillary lymph nodes. So you're going to ask for swelling in the axilla or in the neck. And if the axillary lymph nodes get blocked, it can cause lymphedema of the upper limb. So you're going to ask for arm swelling. Once you've finished locoregional spread, then go to distant metastasis in the form of, one, it can go to the opposite breast or to various other organs, to the liver, the lungs or the bones. So you're going to ask history with respect to those. So very simple, cover it systematically and you're going to cover all the points. One is the lump, next is the nipple, next is the locoregional spread, that is to the axilla or the supraclavicular region or in the neck, and finally the distant spread, that is either to the opposite breast or to the rest of the body. So in specific, what are the history that you're going to take? With regards to the lump, again onset, how did she notice it? Most of the times it is insidious, alright. While having bath or something, they would have noticed the lump. The other way they can notice it is with pain, okay. If there is some sort of bleeding or necrosis or infection that happens inside the lump, then there will be pain, and that is when the patients notice a lump. Or trivial trauma. When I say trivial trauma, by chance the lump will be there since so many days or months, they won't have noticed it. While doing something, they end up injuring themselves very mild and the little pain will be there. When they try, that time they'll notice that there's a lump. So it doesn't mean that the pain is because of the lump. The pain is incidental. So that history has to be elicited particularly. Or sometimes it is even noticed by the opposite sex, like the spouse, during an act of sexual intercourse or something, when that is when they notice the lump. So all these come under insidious onset. Next, progression. Very straightforward. If it's gradual progression or no progression, possibility of it being benign has to be considered. And if it is long standing with a sudden increase, then possibility of it being malignant is high. Then whether it's associated with pain or not, again we said pain can either be because of bleeding or necrosis. Then history with respect to the nipple, whether there is any nipple discharge or nipple retraction. Why is this important? You have a breast, you have the nipple areola complex, and if you have a lump here, we've already discussed that it's going to involve the Cooper's ligament, and the Cooper's ligament will cause, there'll be fibrosis, so the nipple will get retracted towards the side of the tumor. So if you have a nipple retracted towards the upper outer quadrant, it means that the lump is in the upper outer quadrant. Second is with respect to discharge. There is various discharges. You can have a watery discharge, you can have green colored discharge, you can have blood stained discharge, or you can have milky discharge. Now green is commonly seen in ductal ectasia. Blood is seen either in ductal ectasia or it is seen in carcinoma. Alright. So for you, what is important in a case of CA breast is only if the patient is having blood stained discharge, and that also, this blood stained discharge, whether it is from a single duct or multiple ducts. If it is a single duct, it is more likely, if it's a single duct, it is more likely to be because of ductal ectasia or ductal papilloma. And if it is multiple, it is more likely to be cancer of the breast. Next, we said after you ask about question about swelling in the neck and the axilla, you're going to ask about swelling of the upper limb. Okay, whether there is any edema, which will try to tell you that if the patient is having lymphedema. Next, with respect to metastasis, with the whether there is any lump in the opposite breast, and with respect to skeletal system, whether the patient is having back pain, and with respect to liver, we've already discussed either ascites or mass in the abdomen, and only at a later stage will the patient have jaundice. Okay, so don't say jaundice first, jaundice has to come last. Same thing with respect to lungs, dyspnea or pleuritic chest pain first, and at a much later stage they will have cough and hemoptysis. And with respect to CNS, you're going to ask for symptoms suggestive of seizures and vomiting, which is an indirect indicator of raised intracranial tension. Now, past histories, you should ask for comorbidities in the form of diabetes, hypertension, asthma, and ischemic heart disease. Now, why is this important? Because we know for CA breast, surgery is one of the modalities of treatment, and the surgery has to be done under general anesthesia. Now, when you're doing it under general anesthesia, all these factors, that's your diabetes, your heart disease, your asthma, can have a bearing on the outcomes of the anesthesia. So that has to be asked for. Now, the second point is regarding OCP/hormone replacement therapy. This is done and dusted. The debate has been settled. OCPs nowadays have no bearing on the outcome of CA breast. So they are no longer considered as a risk factor, whereas hormonal therapies are still considered as a risk factor. Why is OCP no longer considered as a risk factor? Because the ones what we get nowadays are the combined pills, which have both estrogen plus progesterone, or they are progesterone only pills. They are also called as the POP pills. So as long as progesterone is involved, there is no increased risk of developing cancers. In the earlier days, they used to give them estrogen only pills. So now OCPs are no longer considered as a risk factor. The reason why I'm explaining this is that when you present your case, don't mention there's no history of usage of OCP. Then they'll ask you, why did you ask for OCP? Then you're going to go into the discussion and it's like wasting time. All right. Your focus should be on to try to answer maximum questions with regard to this case, not to deviate it that side and this side. Then with respect to previous surgeries, whether there were any surgeries done in the past on the breast. If it is there, then you mention. Don't mention about other surgeries like surgery in the hand or the leg or the foot or on the gallbladder, the appendix, which has nothing to do with the breast. Don't mention it even if the patient has undergone, because it will not give you any significant improvement in your history or any extra information that you want. Why is surgeries on the breast important? Probably the patient had a benign disease which was incompletely excised, and now the remnant has probably undergone malignant transformation. Or in this benign disease, there could have been some atypia which was missed, and now it has become a malignant disease. So this is a very important history. If it is there, you mention, otherwise you can skip it. Menstrual history is extremely important. Now the common practice is to again classify them as obstetric and gynecological menstrual history. Do not do that, because both of them are part and parcel of the same reproductive system. So you're going to go in a flow chart, okay, in a chronological order. First, you're going to talk about the age of menarche, okay, whatever age, 12 years, 13 years of age. After that, whether her cycles were regular from the age of 12 till the time she had her first child. Now, before you go to the child, you have to tell how many children she has. So obstetric score either in the form of P2, L2 or P3, L2, whatever it is. Okay, obstetric score. Then talk about what was the age at when she developed her or when she had her first child. This is important. Like we said, anyone who is more than 35 years of age when they have their first child are at a high risk of developing CA breast. Next, did she breastfeed her children? Okay. And last is menopause. Now there's another, there's another point that I missed. During the first childbirth, you need to ask whether it was a full-term delivery or not. This is important because at full term, that is at 40 weeks, the breast undergoes something called as terminal differentiation. Terminal differentiation, and this is protective to the breast. Alright, it is protective to the breast. So by chance, if the patient has undergone an abortion at the 3rd month or 4th month, that will not protect her, because the terminal differentiation happens only at 40 weeks. So it's only a full term delivery which gives them a protective coverage towards CA breast. And after this, finally, we're going to talk about menopause, how many years post-menopausal they are. Now, is a post-menopausal cancer better or a pre-menopausal cancer better? The answer is post-menopausal, because that means it is not genetics. Okay, once the estrogen effect and all is gone, if they developed the cancer at a much later stage, and because it is present after such a long time, that means it is a much easier managed cancer. Here, premenopausal means at an earlier age it is coming, so that means the cancer is that much more aggressive. So premenopausal or cancers at a younger age are more aggressive and more dangerous. Now with respect to family history, you're going to ask for similar complaints in the first degree relatives, that is either the mother or the sister. These are the first degree relatives. Then you can also ask for second degree relatives, that is their aunts or their cousins. If any one of them have CA breast, then you need to investigate further. Now, does it have a bearing on this particular patient? No, because she's already developed cancer now. So there's no point getting all these history. But what is important is her first degree relatives, probably her children, her or daughter. You can put them under screening or surveillance. Okay, you can put them under screening or surveillance and probably give them some sort of treatment in order to make sure they don't develop cancer in the future. Now with regards to personal history, pretty much straightforward. There's nothing special in this, except if the patient is consuming alcohol, mention it. And that also, if it's a chronic alcoholic with like an alcohol abuser, you mention it. Otherwise, you can skip it. Okay. And preferably, it should be in a sentence like the patient consumes a mixed diet, her appetite is good, her sleep is undisturbed, and she has regular bowel and blood habits. Don't make it point-wise. Diet, mixed, appetite, good, sleep, undisturbed. Not like that. It should be in a sentence format. Now that you have finished your history, you move on to examination. In examination, first you're going to do the general physical examination, then the local examination, and finally the systemic examination. In general physical examination, because it is a solid malignancy, you have to mention about the Karnofsky's performance score. All right, it's given in most of your major books. Please go through it, and there's an easy way of classifying it. It's 30, then 30 to 60, and 60 and above. So most of the patients what you get are roughly around the score of 90. The scoring are all given in terms of 10, like 30, 40, 50, 60 and up to 90. 100 means they have absolutely no disease and they're completely normal. If they're normal, they'll not come to you. So 100 can never be a score. So most of the times the score will be 90. That means the patient is quite hale and hearty and they've come to you with a disease and it's not troubling them much. Next, you're going to examine the vitals, and the classical after that is going to be your pallor, icterus, cyanosis, clubbing, lymphadenopathy and edema. In lymphadenopathy, don't mention it now. Tell them there is no generalized lymphadenopathy, but with respect to cervical lymphadenopathy, I will describe it later after my local examination. Alright, please mention this because it has more bearing or more importance after local examination than telling it in the beginning. Next, local examination, and finally systemic examination. Now, local examination is done under 4 headings. Normally, that is the inspection, palpation, percussion and the auscultation. But in CA breast, there is no role of auscultation in local examination at least. Then you move on to systemic examination. Now, in local examination also, don't get confused. Again, put them under certain subheadings. As in, these are the various structures that you need to describe. If you follow these 4 points, the chance of you missing out on any point is less. First, talk about the breast. In breast also, you're first going to talk about the breast parenchyma. Then you're going to talk about the nipple. Then you're going to talk about the axilla. Once the axilla, obviously the next structure is the upper limb. And from the upper limb, then you go to the neck. That is the supraclavicular or the infraclavicular fossa. Okay. So the breast, in breast you're going to have the breast parenchyma and the nipple. Then you're going to talk about the axilla, the upper limb and the supraclavicular and the infraclavicular fossa. Now this has to be done in all inspection and palpation, both the headings, all 4 areas have to be seen. Now the local examination of the breast is done in 3 positions. One is sitting position because the breast is relaxed and it's hanging down. Next, on bending forward, you're going to see whether the breast falls forward or whether the tumor has infiltrated the chest wall. And the semi-recumbent or the recumbent position, that is where you're going to palpate for the breast. So now, why do we do each of these positions? First, let's talk about the bending forward. Sitting, we know, is pretty straightforward, but when do we do the bending forward? So again, you're looking from the side. These are your ribs. This is the pectoralis major. And you have the breast in front here. If the lump is here and you ask the patient to bend forward, both the breasts will fall forward. Okay. But if the lump is gone posteriorly, okay, posteriorly, and it is gone beyond the pectoralis major, if it's involved the chest wall, when you ask them to bend forward, the breast will not fall forward because it's hanging. Alright, the carcinoma is holding the breast from preventing it from falling forward. So you're going to look for infiltration of chest wall when you're asking the patient to bend forward. Next is the recumbent position. When a patient is sitting, the breast is like this, in this shape, okay, because of the suspensory ligaments of Cooper. Whereas when you ask the patient to lie down, okay, when you ask the patient to lie down supine, the breast kind of flattens out over this area. It goes laterally, it goes medially, and it is flat over the chest wall, and you can palpate it or examine it better in this particular position as against sitting position. Next is with respect to position of the arms. Again, here there are 3 positions. One with the arm by the side of the body where the patient is relaxed. Second is when the patient's arms are raised. And third is with the arms on the hips. So let us see regarding raised and when the arms are on the hip. So first is when the patient's arms are raised. Okay. So this is the shape of the breast. So there are certain things that you can't see. First is the inframammary region. Second is the axillary region. Okay, with the arm which is next to the patient, you can't see the inframammary and the axillary region. So when you raise the arm, The first thing that you can see is the axilla. Second is the inframammary region. Okay, because these are two blind spots which are missed with the arm next to the side of the body. Okay. The other thing that can happen is, for example, if the tumor is here and it is involving the Cooper's ligament, probably in sitting position there is no dimpling or puckering, but when you ask the patient to raise the arm, the breast shape will become more flattened because it's getting stretched. So that time when it gets stretched, the lump is still here, but the Cooper's ligament will get stretched. So when it gets stretched, you're going to have dimpling or puckering. Alright. So the dimpling or puckering which is not there in sitting or the relaxed position can appear when you ask the patient to raise their hand, and something similar with respect to the lump also. If the lump is sitting deep within the breast tissue, sometimes you might not see it, and once it flattens out and if the lump is slightly bigger, sometimes the lump might become more prominent. So the four things that happen when you ask the patient to raise their hand: one, you're going to look for the axilla; second, the inframammary fold; third is accentuation of dimpling or puckering; and the fourth is prominence of the breast lump if it is visible. Now with regards to arms on the hips, you're going to look for movement, because when you ask the patient to put the arm on the hip and press, you're putting the pectoralis major into contraction. So you're trying to see whether the tumor has infiltrated the pectoralis major or not. Now let's look into the inspection of the breast. First thing that you need to, most of the times because the lump is inside the breast, you can't see the lump directly. Okay, it's a palpatory finding. So, but what happens is, if the lump increases in size, the breast can also increase in size. So you're going to look for size of the breast. Now there is no way of measuring the breast because you can't say it is 10 into 14 centimeters, something like that. So you're going to compare it with the opposite side. Okay. So compare the breast with the opposite side. And how are you going to compare? You're going to compare the nipple areola level. If both the nipple areola are at the same level, or if this breast has enlarged because of the tumor, the nipple areola might be lower, or by chance if there is a scirrhus or an atrophic tumor, it has got shrunken and the nipple areola is at a higher level. So this is the first point that you're going to see on inspection. Then see whether there is any obvious dimpling or puckering or peau d'orange, that's how it's pronounced, and we normally call it as peau d'orange. This is a skin involvement. Okay, where the tumor has involved the skin. Now let us see why this happens. So if this is the surface of the breast, and on these skin you're going to have hair follicles. Okay, now for some reason the tumor will block the lymphatics of this region, because the lymphatics get blocked because of the tumor cells. So when this happens, you have your hair follicles. Now when this happens, there is edema in this region. Okay, but wherever the hair follicles are there, that area can't come out because it's like an anchor, but the rest of it will blow up. Okay, so when you look from top, you're going to have an edematous region with small tiny dots that you can see like puckered, something similar to an orange peel. Okay, that's why they call it as peau d'orange. So this is skin involvement. So what are the other skin involvement? First is ulceration. We know ulceration is pretty straightforward. If you have ulceration, that means it has already gone to the skin. Second is peau d'orange. Peau d'orange. Third is satellite nodules. So these are the only three conditions where you're going to say the skin is involved. Satellite nodules basically means it has infiltrated the skin, and from here it has started traveling along the skin to a local region of spread like the lymphatics. So if you find hard nodules in the skin, they are satellite nodules. And finally, you're going to talk about the lump if it is visible. So far we have only talked about the size of the breast, then if there is any dimpling or puckering or peau d'orange. Now you're going to, if you can obviously see a lump, describe the lump. Otherwise you can just say I've noticed a fullness in the upper outer quadrant or something like that, and then describe it better in palpation. Now with regards to nipple, you're going to ask for retraction and discharge. You can obviously see retraction as to which direction it's gone. We've already discussed whichever side, if this is the nipple, whichever side the cancer is, that side will be the retraction because of the involvement of the Cooper's ligament. Alright, the Cooper's ligament will be involved and it retracts the nipple towards the side of the tumor. Now with respect to discharge, on inspection you can't press, okay, pressing is a part of the palpation. So you're going to look for the undergarments, okay, the inner surface of the undergarments, whether there is any staining, okay, that will give you an idea about the nipple discharge. Now regarding the axilla, you're going to ask the patient to raise the arm. You're going to look for, like we discussed, the axilla, the inframammary fold, any prominence of the dimpling or puckering or any prominence of the lump. So these 2 points, if it is there, you have to mention, otherwise no need, but these first 2 points must be told. Okay, and if there is a swelling or a fullness in the axilla, please mention there is a fullness in the axilla and then describe it better or well in your palpation. Next, you ask the patient to bend forwards. Now this is important because it will tell you whether the cancer has spread posteriorly either into the pectoralis major or the chest wall. Now both of these make a difference because there is a difference in the staging of the tumor, because if it involves the pectoralis major as against to involving the chest wall. We'll discuss about it once we finish the diagnosis and we go to the level of staging. So once you have finished the breast, the nipple and the axilla, now you talk about the upper limb and you're going to talk about the supra and infraclavicular fossa, whether there is any fullness, whether there is any edema, whether there is any obvious abnormality. Otherwise you say these areas are normal. And palpation, we already discussed why we are doing it in the recumbent position, because the breast flattens out. And use your palm or the palmar aspect of your fingers. Don't use your fingertips and try to grab on. The reason is, we all know about Andy, which is an aberration of the normal development and involution, and one of the condition under that is called fibrocystic disease. Okay, it is no longer used because it comes under the category of Andy. So when there is a fibrocystic disease, what happens? The breast parenchyma itself is a bit nodular, and when you try to grab onto it like this, it will feel like a lump. Okay, but in reality there is no lump. There are only small cysts which are just close to each other, and when you hold on to it like this, you will feel like it's a lump. Instead, make them sleep and palpate. Now you can't feel the lump, you will only feel nodularity. Okay, you'll just feel that there is something irregular, little nodular, but you can't find the same lump you felt when you were trying to hold on to it. That's the reason you're going to use the palm or the palmar surface of your fingers as against to using your fingertips. Now, you should always examine the normal side first and then the affected side. But when you're explaining or when you're presenting the case, always present the positive findings. There is a pathological side first and then mention about the normal side. So again, in palpation, like any other swelling, the first 2 points will be the tenderness and the temperature, whether the swelling is tender, whether there is any local rise of temperature. Then with respect to the lump, just like any other swelling, the site, the size, the shape and the extent. Now in extent, you can either use anatomical marker, the surface anatomy, or in CA breast, it is quite acceptable if you just say in which quadrant it is. You don't have to say from extents from here to there to here to there. So you can just say either it's the upper outer, the inner outer, the lower outer, the inner lower or the inner upper quadrant. Okay, so if you say the quadrant, it's quite enough. But if examiners do insist that you need to specify the bony landmarks, if this is the CA, if that is the breast, medially you're going to use midline as your marker, laterally use the anterior axillary line. How do you identify the anterior axillary line? It is nothing but where your pectoralis major muscle comes. Medially will be the midline, and superiorly you are going to use the clavicle. Okay, the clavicle will be like this. So superior border will be the clavicle, and the inferior border will again be clavicle. If for example the tumor is here, so say superior border is 2 centimeters, the inferior border will be 5 centimeters from clavicle at that point of time. Okay, so both superior and inferior extent you can use clavicle as your marker or for the surface anatomy. Next, when it comes to mobility, there are 2 mobilities that you need to look for. One is the mobility of the lump with the breast tissue. For example, if this is the breast and this is the lump, in CA breast, it infiltrates into the surrounding fat. Okay, so when you move the lump, if you move the lump front and back, even the breast also moves front and back. Okay, that is a characteristic feature of CA breast, as against fibroadenoma, where if you move the lump front and back, the breast does not move. It's only the lump which is moving. That's the reason it is called as mouse in a breast, because it moves independent of the breast tissue. Alright, so how do you do this test? You cup the breast in one hand, and with the other hand you try and move the lump. If you feel the breast is also moving when you do this, then it is CA breast. If you feel that this part is stable and only this lump is moving around, then it is a fibroadenoma. Second thing with respect to mobility is pectoralis major. We know that the pectoralis major fibers are aligned in this particular direction. So the first thing, the way you examine it is you ask the patient to put their hands on the hip, but don't press, just put the hands on the hip, check for mobility of the lump, then ask them to push on the hip. The pectoralis major becomes taut. So feel at the anterior axillary line, make sure the pectoralis major is taut, and then check for mobility of the lump. So the mobility of the lump is checked in two directions. One is perpendicular to the fibers and second is along the fibers. But what is more important of the two is along the fibers. Now why is this? So one is perpendicular, one is along the fibers. So please understand, when you do a perpendicular movement like this, sometimes you might move the entire pectoralis major muscle itself along with the tumor. So you can have pseudo mobility. Whereas if it's along the fibers of the pectoralis major, here because it's origin and insertion, and there has to be two proper bony landmarks for that. So you can't move the bone when you're doing that. So here, this will give you actual mobility. So when you're saying if there is restricted mobility, when you're presenting it, please present that the swelling is otherwise mobile, but there is restriction in mobility on putting the underlying pectoralis major into contraction. Don't say underlying muscles. Okay, be very specific as to which muscle you put into contraction and along which direction, along the fibers of the pectoralis major. Finally will be your consistency. You're going to check whether it is a hard lump or whether it's a firm lump. A hard lump is more in favor of a malignancy and a firm lump is more in favor of it being a benign disease. Then you're going to examine the axilla. Like we have discussed, you're going to examine the anterior, the posterior, the lateral, the central, and these are the four groups of lymph nodes in the axilla that you're going to examine. The apical is not usually palpable, but certain textbooks do mention this, as in very old textbooks, where using a bimanual palpation. One hand into the supraclavicular fossa and the other hand deep into the axilla, and you try to meet these two, okay, and see if you can find any lymph node between these two areas or some mass which can be palpated between these two, and they consider this as an apical group of lymph nodes. This is again more or less just theoretical. If you get a senior examiner, if they ask you, you need to know about it, but in your clinical and day-to-day practice, we do not practice this. And in the neck, you're going to check for supra and infraclavicular regions. Now, this is important because we have discussed from the axillary, it can go to these regions, which is the level 3 group of lymph nodes. So, you need to examine that as well because they're easily accessible. Now, with respect to percussion. Now, if this is the sternum, you have the ribs. Okay. Now, apart from the axillary group of lymph nodes, we have read that it can also spread to the internal mammary lymph nodes, and internal mammary lymph nodes are on the inner side of the chest. Okay, it's inside the thoracic cavity, so you can't palpate it. You need to percuss that region. So you're going to percuss in the second, third, and fourth intercostal spaces, and you're going to look for a resonant note in the parasternal region. So if you get resonant, it tells you that nothing is there behind. So there is no internal mammary lymph node enlargement. Don't say no internal mammary nodes. The nodes will be there, but they're not enlarged or they're not pathological. If it is dull on percussion, when you're percussing, if it is dull, it maybe internal mammary lymph node enlargement, or it can be any thoracic tumor. Okay, it can be a retrosternal goiter, it can be thymoma, it can be mediastinal mass, it can be anything. It possibly can be internal mammary lymph nodes, but doesn't mean that it is. The only way you're going to make out whether it is internal mammary lymph nodes or not is on radiological imaging, that is either with the help of CT scan or MRI. Next, we have discussed on examination of the spine, you're going to check for paraspinal tenderness because you're going to try to rotate the spine rather than just push it. You're going to try to forcefully rotate in order to see whether the patient is having pain. Now on systemic examination in the abdomen, we have already said you're more interested in getting ascites and hepatomegaly. And in respiratory system, you're going to look for evidence of pleural effusion in the form of decreased air entry. And only in the later stages can you have cannonball appearance and Krebs. Now per rectal examination, normally I don't think we expect this from an undergraduate in the exam, but for a postgraduate, they do ask why didn't you do a per rectal examination? You're supposed to do per rectal examination only if you have evidence of ascites. Otherwise, don't keep doing per rectal examination for everyone. It doesn't give you any extra information than what you already have. And in per rectal examination, the thing you're going to look for is Blummer shell, which is basically deposits in the pouch of Douglas. So the deposits is again drop metastasis. So unless the liver is involved, you won't have drop metastasis. Okay. So first you're going to have ascites or hepatomegaly. Then only you're going to have Blummer shelf. If you don't have ascites or hepatomegaly, there's no question of Blummer shelf arising. So now that you have your entire information, then you diagnose the patient and give your diagnosis that will be in the form of carcinoma of the right or the left breast, and based on the TNM staging, whatever it is, T3, N1, M0, whatever it is. Now the last bit about this class will be on staging. This is a theoretical topic where you need to mug up a little, okay? But probably the more number of times you revise or the more number of times you use it, you tend to understand and remember better, all right? So in every staging, we have what we call as a TNM staging, all right? T stands for tumor, N is for nodes, M is for metastasis, all right? So first, let's look at the tumor staging. In CA breast, very easy, T1, T2, T3 and T4. In T4, you have A, B and C, okay? Less than 2 centimeters, 2 to 5 centimeters, more than 5 centimeters, and A is for involvement of the chest wall, B is skin involvement, and C is both chest wall and skin involvement, okay? Now T1, T2, T3 are pretty straightforward and self-explanatory, but we are more bothered about the A and B. When do you call it T4A? When do you call it T4B? So let's just have a look. This will be your ribs. This is your pectoralis major muscle. This is your breast. This is one scenario. And this is the second scenario, where you have the breast and the lump has gone beyond the pectoralis major and is involving the chest wall. Here, in both the cases, the breast will not fall forward, okay, because both the cases they are stuck onto something on the posterior aspect. But what is important is only this classifies as T4A. If it involves the chest wall apart from the pectoralis major. Just because it infiltrates pectoralis major, it doesn't make it advanced. Now, it's very common sense. If it's involved the pectoralis major, earlier days, they used to do what we call as radical mastectomy, where they used to take off this entire region. Okay? So, which basically means that this area can be sacrificed. It can be taken off. So, it means that it's not that advanced or it's not a vital structure. Whereas here, you can't just take off the rib cage like that because you're exposing the thoracic cavity, alright. So basically means that it is more advanced, it's as simple as that, okay. So T4A means it has to infiltrate the chest wall, okay. If it infiltrates the pectoralis major, it doesn't classify under T4A, it only depends on the size. If it's a Small tumor, if it is less than 2 centimeters, you still call it T1, even though it's infiltrating the pectoralis major. If it is 3 centimeters, you call it T2. If it is 5 centimeters, you call it T3. Simple. Only if it goes beyond, that it involves the chest wall, you call it as T4A. Okay. Now, skin involvement. We've already discussed skin involvement will be ulceration, pudy orange, and satellite nodules. Okay, these are the only three which classify as skin involvement. Dimpling, puckering are not skin involvement, and we have discussed this. This is because of involvement of the Cooper's ligament, not the skin. Okay, so I hope this is clarified. So this will be T4A, this is T4B, and if a tumor involves both the chest wall and the skin at the same time, if it's a very atrophic or a serous tumor, it might cause shrinkage and involve both the sides, then you call it as T4C if it is A plus B. Alright, so this was regarding the tumor staging. Then we have the nodal staging. You have N0, N1, N2, N3. I will not go into the depths. Basically means that as the staging goes higher up, the level of lymph nodes involved also will be higher up. For example, here it will only be axillary, here it will be axillary or internal like fixed axillary or internal mammary. Here will be the supraclavicular, infraclavicular, or axillary plus internal mammary, where both the regions are involved. Okay. So the nitty-gritties will not go into it, but you just need to understand the higher is the nodal staging, it means the farther it has gone. First will be the axilla, next internal mammary, then supraclavicular. So N1, N2, N3. Okay, that's the way to remember it. And finally the M staging, M0, M1. If it is gone, if there is no metastasis, M0, M1 will be either to the spine or to the lungs, the liver, or CNS, the brain. Okay. Now the last bit is regarding staging. Now staging is classified into stage 1, stage 2, stage 3 and stage 4. We'll discuss about this in detail when we go into management of the cancers. That is because stage 1 and 2 are called as early breast cancer. Stage 3 is called locally advanced breast cancer. Stage 4 is called advanced breast cancer. Now each of these have different combinations of T and M. Okay, like T1, N0, M0, T2, N0, M0. So it's very confusing, but we'll make it very simple when we talk about management and evaluation of a CA breast. Okay, thank you.